They have decent arm strength. Something that's not here, you may have seen in a clinic. It's actually stationary, but we still call it an assistive device. This might be the first place someone begins to ambulate. Do you know what we're talking about? Parallel bars, very good. You guys usually, maybe because I cued you because it's stationary, usually we're in the other room and it's there, and usually it takes people like 20 minutes to figure that out. So yes, parallel bars are considered an assistive device, even though they aren't going to be ambulating in the community with them. But it is a place, usually in an inpatient scenario, where that might be the first place someone ambulates. It may be one therapist, it might be two therapists helping that person out depending on how weak they are, what the situation is. Moving from there, walkers will generally be our most stable devices. What is the difference between these two walkers here?
One has wheels. Front wheel walker.
Front wheel walker, what's this one called?
No wheels. No
No
wheels.
Four-wheel drive.
No wheel drive.
So how many wheels does this have? So is it called a zero-wheel walker? Yeah, it's a standard walker.
Normal one.
Which one of these is going to be more functional? The wheeled walker. So this one is pretty stationary. However, a patient with significant balance issues, would this one be a better choice, or would this one be a better choice? So let's think about this. I have really bad balance issues. So yeah, this one a little bit more stationary. People might bear more weight through their arms, but if they have a fear of falling or significant balance issues, significant weakness, this one's actually going to be more limiting because they have to lift it off the ground. So this one here would be your better choice if you have someone who has big balance issues. They're able to not have to lift the entire device. They have relative support the entire time. But someone who's like really trying to bear weight through their arms might have a hard time with this one because they might just keep pushing it forward in front of them. So those are some of the considerations that we have to make when we are talking about gait training. Fear of falling increases the risk of falling. There's a lot of outcome measures that are kind of like question based, and fear of falling increases their score as far as their risk of falling goes. So if they have that, they should not be using this device here because they would be significantly more likely to fall, and that is an important thing to take note of as we move forward with our devices. Anything to add about walkers?
There is one called the reciprocal walker, and I was checking to see if we had it, but it's in the other room. And that it makes you go a little bit slower, almost like a shuffling gait pattern, so I really don't like it. But it'll move one of the sides and then the other side. I don't know if you guys have seen it.
Yeah, so I've seen it clinically once for a patient with MS that already had a very, very small step length. So she basically wasn't really going to improve from there. So basically the main difference is these pieces here are mobile that connect, so you kind of do this thing, but it's a very small limited step length. We'll look at it when we get over to building C, or we'll grab one a little bit later. But yeah, you're very, very limited as far as what you're able to do with that. Turning is very difficult, so it's really not the most functional. It would be very specifically used in some long-term neurological conditions where the step length is already limited, but that's pretty much the only time I would expect to see that in use. Sometimes, what do we see on the back wheels of our front wheel walkers?
Tennis balls.
What do we think about those?
Friction, there's less friction when you're sliding.
Yeah, it decreases the friction. What is a property that tennis balls have when it comes to like water? Yeah, they're absorbent, right? Where do people take walkers? Everywhere, including
On your floors.
bathrooms. So we typically don't really like tennis balls for sanitary reasons. They make rubber, like for some reason people like the look of tennis balls on their walkers, I guess. So they make like rubber ones that you can put on. But definitely, I would recommend like going away from that. They do make little like ski sliders as well. So there are other options you can recommend if you see your patient throwing those on the back of their walker.
Is it typically just because they don't want to scuff their floors?
Could be, yeah. But yeah, so again, that's where like the rubber kind of tennis ball option. But again, like patients, you should be teaching them how to use the device correctly and not sliding it. There also are 4-wheel walkers. We don't have any in this room. There's a couple in the other room. But have you guys seen like CVS sells them? So there's 2 handles usually, brakes, and then there's a seat, and usually you can open it up and they can. So those ones are good for someone who's a little bit like doing stuff on their own more because they have the opportunity to get tired, turn, take a seat. What we don't want to see is using it as a wheelchair. We do see that quite frequently, but that is a very high risk for falling. So unless the patient was out and like absolutely could not walk anymore and you just like had to get them back to the car or something, I would never recommend to your patient or your patient's caregivers to let them push them around in that like it was a walker or like it was a wheelchair, sorry. Those ones, again, are nice because there's no lifting involved at all. However, again, if they're really trying to bear more weight into their arms, they might just kind of run away with it. Other things people will do with those walkers is like hold on to the brakes, like if they're going like downhill, or even patients who are doing more weight bearing through their arms to kind of slow themselves down, and then they wear out the brakes, and then the brakes don't work anymore, and then they, again, are at more risk for falling. So what types of patients would we think would be on our walkers?
People with lower back issues or not too big of hip mobility.
So why would hip mobility be a consideration in what device you're using?
Just for the flexion of the hip and the range of motion, and just for balance wise.
So I would say if we're getting our PT brains going, what did we start teaching at the end of last session?
Oh,
The guarding.
Yeah, last PCM class, I know, as far as like a few weeks ago. What did we start teaching to help make decisions for transfers and bed mobility?
Like minimal assistance versus maximum assistance?
All right, somebody had a stroke or a total knee replacement.
Oh, the gross muscle testing?
Yeah, muscle testing.
that's
So regardless of diagnoses, our PT brain should, the diagnosis is important, but it's not going to dictate everything we do because different diagnoses can present differently. We are using those muscle tests in order to establish how strong our patients are. So patients who are definitely on the weaker side, like closer to like a 3 all over, those balance issues, those are more the patients we would think we would be using a walker for because they're not strong enough, safe enough to use some of these more independent devices. But anything that you just said, for the most part, could present that way, right? Low back issues, maybe post-surgery. Generally, a lot of our post-op patients, especially if we're talking more like total knees, total hips, for safety, if your patient is on, the older side and they have a fall, a fractured hip is actually greatly increases the risk of, or the likelihood of death in like the next 3 years. So keeping those patients extremely safe when we're on the practical. If you're kind of in between, like, oh, they could use crutches, they could use a walker, especially where we're talking about the first time working with patients in this class. If you go the safe route, you're gonna be safe from losing points. So starting out safe and then progressing them as quickly as possible after that is a good way to go. Typically, like, so talking about surgeries, like someone who's injured their ACL, what type of patient does that usually look like? Athlete, usually, like how many 65-year-olds have you been treating for ACL injuries? Not very many. So usually those types of injuries, like did you see anyone in high school walking around on a walker after spraining their ankle or, no, they get crutches, right? So these are going to be our standard crutches. They require a little bit more trunk control and stability than this does. Still requires decent amount of upper extremity strength. So that's kind of a prerequisite. These are the same height. They're just very short for me, so talk about sizing devices appropriately. Just in general, talking about these skills, the bed mobility stuff is very important, obviously, and transfers. The bed mobility, if you're not inpatient, you'll use it a little bit, mostly like post-spine patients. You'll be like teaching log rolling and how to move around, like maybe when you see them in the clinic. For the most part, transfers you'll use a little bit more if you're not in like an inpatient neuro setting. But gait training, sizing assistive devices, no matter what setting you're in, these skills are all going to be very important. Patients will always like have weirdly sized devices and they'll be like, oh, like my nurse or like my brother sized it for me. And you're like, well, you need to talk to them nicely. Sometimes patients are very resistant to having their assistive devices changed. But usually talking to them being like, oh, let's try this. I think this might work better for this reason. And I always just say if we don't like it, we can always change it back, and then usually that at least gets them to try it. And then usually when you size it correctly, they're like, oh, this does feel better, and then that increases your patient buy-in. So typically crutches are going to be more your younger, non-weight bearing patient initially. But there might be other instances where someone a little bit older has been using the walker, but are these easy to take up and down stairs? No. So if you have your patient on the walker initially, but they have stairs at home and they're having trouble with that, progressing them to the crutches if they have sufficient strength and balance is going to be good. Who else might use crutches, Lizette?
Are we doing the age thing also?
No, so we're not. So we used to teach age 65 and older. You would always 100% start them on the walker. That is not supported by your lecture material, and residential hasn't been teaching that for a while either. So I decided that we'll stop teaching that as well. However, I would strongly recommend if your patient is 65, unless they are presenting with like really good strength and balance for the reasons I said earlier about if they do have a fall, especially if it's after a hip replacement, it would probably be in your best interest to start them on the walker, even if they were a little bit stronger.
Usually your patient that has, like Dr. Parker said, good balance, good upper strength and coordination also.
So these are also called axillary crutches because where they end up is in your axillar region. If I was to have need for crutches for a long period of time, maybe I have a neurological condition, and again, like I'm good enough with my balance and gait that a walker would just slow me down too much, be too cumbersome. Would this type of crutches be ideal for long-term use? I see you kind of shaking your head no. Why?
I mean, I don't have like a great reason for it, but I had a patient, I don't remember what was going on with his knee, but he was using crutches for a while, and he kind of like started feeling sensations like in his arm. So then my PT, like eventually he didn't need the crutches, but when he still kind of did, she gave him something to do to kind of help with that.
She gave him something to do.
I don't know. He would just sit there and go like this, and I'm like, I don't really see how this is helpful, but.
Okay, so he was having symptoms going down his arm from using axillary crutches for an extended period of time. Why was that happening? Yeah, your brachial plexus is up in here, right? So ideally, when we show you how to size the devices, this is a little short for me, but it shouldn't be pressing all the way up in here anyways. It should probably be right about here. You should be able to fit about 2 fingers in between. But patients, when they're using them a lot, they'll get tired and they'll start to lean on them. And that can cause long-term brachial plexus compression and damage, and obviously we don't want that. So, usually your post-op patients, 6 weeks, 8 weeks at like most of using crutches typically is gonna be okay. But if we have like a long-term neurological condition, or a patient whose surgery, for whatever reason, they're going to be using crutches longer, might use these guys here. Let's go down like 2. Yeah, 2 from where it was. What are these called? Anyone know?
Something crutch.
Crutches?
Forearm crutches.
Forearm crutches or loft strand crutches are the more. Something about Mary, right? So what was his
Oh my god.
fake diagnosis in that movie? I don't remember. I think it was Guillain-Barré syndrome, or no, I think it was a spinal cord injury. I think it was a spinal cord injury. So partial spinal cord injury, not complete. So he still had some use of his legs, but not really expecting to improve from that condition. Someone who's going to need devices for the long term, more functional cerebral palsy patients, Guillain-Barré patients or Guillain-Barré patients who aren't as far along in the disease process, possibly MS also early on. So there's a lot of different, usually neurological conditions that could be using these, and again, it just requires significant more trunk control, upper extremity control and strength, because you don't get the trunk support with these. So a patient that might be using something long term but doesn't have the sufficient trunk control, what would you do? Because you don't want them to use loft strand crutches because they don't have the trunk control. They're using devices long term, so you don't want them to use axillary crutches. What would you do? Ferris? Bueller? They can't use loft strands. They can't use axillary. Yeah, you can go back to a walker. That wasn't that hard, was it? You guys need to do some like jumping jacks and wake up.
I just thought that was taken out of the equation.
No, it's not taken out of the equation.
I didn't know those were
It's
the
trying to
options.
get your brains thinking about progressions and regressions.
I didn't
That's
think
all.
you go back.
Yeah, so it's never like a patient has to use crutches or has to use that. So again, we're looking at their condition, talking about the variables, and making the necessary changes as we need. So that is our loft strand crutches. These ones actually would probably more be called forearm crutches.
Video game.
Yeah.
Oh my.
Why would I be using these?
Take pressure off the wrists.
You don't have good motor controls or wrist trunk.
Yeah, so perhaps poor motor control at the wrists. That would be a valid reason, maybe. What else? You said why else would I want to take pressure off of the wrists?
If there was a fracture. Then
Yeah, there could have been a fracture. They might be non-weight bearing through their distal upper extremity. The shoulder and elbow are in good integrity. They need something to get around. So then they would use something like this here. There might be patients who could use loft strand crutches and would maybe just prefer to use these to get a little bit more support through the arm and the shoulder. And then there are also forearm attachments for the crutches, or sorry, for the walkers. So same thing, if you had a patient that had a significant fall, maybe they had lower extremity and upper extremity injuries, then they might need 1 or 2 forearm attachments to go on their walker so that they get more upper extremity trunk support without the weight bearing through their wrists. Oh, and we have other versions here. With the crutches, any type, they can be a unilateral or bilateral device. So a lot of times progressions when you go from non-weight bearing into weight bearing, you might end up removing one crutch and then you kind of see something more like this. And then we're moving on to typically single arm devices. Again, with the single arm devices, you can use 1 or 2. It's usually rarer to see 2 canes being used, but there are definitely times that I've seen it. Usually it's 2 single point canes as opposed to any of these other devices. And that might just be someone who usually uses 1 cane, but walking longer distances, they want to use 2. Which one of these would be our most stable device?
A wide base.
This one?
Oh. That one.
Has anyone seen this one before?
A little better.
So people have seen it before. What type of patient was using it?
Hemiplegia,
Yeah, so what diagnosis usually is hemiplegic?
post-stroke.
Yeah, so usually, so this is, the way I remember this one, hemiplegia, hemi-walker. So, a stroke patient who ideally you want to put on a walker initially, but they don't have use of one of their arms, this would be your next best option. Why would I not want to use like a forearm attachment on a walker for a stroke patient?
They lose their
What is
balance,
it?
they take.
They won't use one side.
You want to be, because you don't want to be in that same, because when they're sitting down in the hemiplegia, don't you want to keep them moving anyway? Like moving their limbs, so that aspect, you don't want their arm to be stationary that long?
I mean, you don't want the arm to be stationary that long. However, sometimes early on, or even I have one patient right now who his stroke was pretty severe. And he's like 6 months out, but we're still putting him in a sling when he's ambulating because we don't want his arm just completely dangling. So the arm could still be like restrained for support if needed, but why would the forearm attachment on the walker not be as ideal for someone who has some control but not very much control of their...
They might try to depend on it too much and then not realize they don't have the strength.
Is it because they don't have sensory, so they won't realize if they're hurting themselves by putting pressure on that?
That would probably be the main reason. We talked about it a little bit, but if they don't have much sensation, much control, what are they at risk for doing on their affected side? In the shoulder specifically. Yeah, dislocating, subluxing. So if they don't have much sensory, much motor control, and they are trying to bear weight through it, there is a risk of subluxing. There's obviously a risk of falling because they're trying to put more weight into that side. And then the other reason, if they don't have good control, trying to get their arm into one of those apparatuses just might not be very feasible for them either. So using this device, usually there isn't going to be a diagnosis that you would use this with other than a stroke. You could make cases for, you know, progressing someone off a walker to a single device for some reason. There could be like a TBI patient who had one side significantly more affected than the other, and not having use on that one side. But typically this will be usually just your stroke patient, and usually the stroke will be a little bit more severe earlier on in the treatment care. So moving from here, we have wide base quad cane and narrow base quad cane, and then our single point cane. Theoretically, these devices are more stable because they have the wide base. So if you're answering questions on the written exam, you should assume that this is more stable than this. On the practical, if you're talking to me about moving from a hemi walker to this, that is totally acceptable. However, clinically, I am not the biggest fan of either of these devices because it gives you, in my opinion, a false sense of security where, you know, if you're here right over the base, you're good. But once you go a little bit, see how you kind of quickly just lose it. So patients will end up trying to bear more weight through this device, but there are more falls with this because they bear more weight through it. And once you get a little bit outside of that base of support, it can go pretty quickly. Whereas this one, even if I'm leaning this way, I'm not getting like that quick loss of balance, and I can still kind of control it. Only having one point of contact on the ground, it just makes it's a less quick distribution of losing your weight when you're moving. These are very good for patients who live by themselves. Maybe they need to do a lot of stuff around the home, so they'll take this into the kitchen, put it down next to them while they're doing some cooking, whereas a single point cane obviously can fall. Patients will lean it up next to something, it can fall, and then patients are at risk for falling if they are trying to pick up their cane off the floor. So typically, clinically, the only recommendation I have for people using these is when they're in the home by themselves and they need to do other stuff using their hands frequently. Whereas for general ambulation, I would prefer them to be using one of these. I would probably have them using like a walker outside of the home if they're really not ready to use a single point cane. These I will use like in the clinic if I have them available to bridge the gap between this and this. But again, independently using these, I don't really like it because I feel like it increases the risk of fall. I know in residential, other instructors have different opinions and they like these devices, but again, just from what I've seen, does that remind me, do you agree with me or do you disagree with me?
I agree.
Yeah, see, so we're on the same team here. And then single point canes, obviously they provide the least amount of support. You can bear some weight through it, but generally people need to be using this more as just an aid to relieve some pressure, slight balance assistance, and more so sometimes people just kind of carry these around as like a, hey, I am a fall risk, I had an injury, please don't bump into me, because usually people see someone holding a cane and they'll be conscientious of that and try and not bump into them. Okay, that is everything.